Any IT persons are there?
Yes,
We
sir.
are going
I'm
to
here.
start.
You can
Yeah,
start.
yeah, yeah. I'm going to start now. Yeah, I'm going to start now. Yeah. Okay. Good afternoon, one and all. On behalf of Respiratory Medicine, Sri Manakumala Medical College and Hospital, Pondicherry, India. So I welcome you all for this global webinar on COVID-19 pandemic. First of all, I would like to thank Professor Michael Kreuter from Heidelberg, Germany, who is an expert and a global leader in interstitial lung disease and idiopathic interstitial pneumonia, for accepting this invitation, sir. So I met Professor Michael Kreuter 2 years back in ERS Paris, and also last year also. We worked together, and he helped me a lot during one of the most important session on in ERS Paris clinical grand rounds. I think sir might remember that, and he guided me a lot at in that session, so that it was really interesting session in ERS Paris. He is an excellent orator and good teacher also. Thank you, sir. Thank you for accepting our invitation for this global webinar, for this knowledge sharing platform, live from Germany and also from India. And next, I would like to thank Madam Professor Ashu Bella, Professor of Radiology, renowned radiologist. She's an excellent orator and a great teacher. Thank you, ma'am, for accepting our invitation on this pandemic season, so that it will be a good knowledge sharing platform, so that will be helpful for all the physicians who are organized here. So without wasting much of time, we will move on to the first session, that is on perspectives of chronic lung diseases, but like interstitial lung disease or chronic airway disease in this COVID-19 pandemic season. So I would like to invite the Professor Michael Kreuter from Germany. Before his speech, let me give a small intro. It doesn't need any introduction. Professor Michael Kreuter is at present the head for the Center for Interstitial Rare Lung Diseases, Pneumology and Respiratory Critical Care Medicine, Thoracic Clinic, University of Heidelberg, and Translational Lung Care Center, Heidelberg, Germany. He was chair at in the ERS for interstitial lung disease, and course director for various ILD, not only in Europe, all over the world. He has n number of research publications to his credit. Over to you, sir. Over
Okay,
to you,
so
sir. You can start, sir. Yeah, yes, sir. Yeah.
first of all, thank you very much to this honorous invitation, and it's a pleasure discussing with you about the chronic pandemia we are currently having in the light of chronic lung diseases. So please first let me give you a little bit about our thoughts and the situation we are currently in Germany. So the first COVID-19 cases were notified in Germany in January. Currently, with the update of 2 days ago, we had about 130,000 confirmed cases. And we do have it all over Germany. Germany is divided into 16 federal states. However, it's mainly the south of Germany, which is also the federal state where I'm living in, the so-called Baden-Württemberg federal state. We and Bavaria, together with the North Rhine-Westphalia, which is close to Essen, we have the most cases. Most cases, most interestingly, are more younger people. About 70% of them are between 15 and 59 years old. And from the data we do have, men and women are equally affected. However, if we look into the situation of those who die or are more severely affected, it's mainly those who are aged 70 years or older. However, they only represent about 20% of all the cases. This is also perhaps in line with what we are facing currently. We do see some outbreaks in nursing homes and also in some wards of hospitals. So this is one of the reasons why we now have more aged people than before. What we do have is we still have many patients in ICU. They are now mainly COVID-19 negative, but many of those patients are still ventilated. It's about 75% of about 2,500 people here in Germany who are still on the ICU. And from the more than 5,000 people who were discharged from ICU, about 30% of these people died. This is all very sad numbers. However, if we compare the numbers we have in Germany to other countries, for instance, to France or to Spain, and especially to Italy, we see that Germany is not that severely affected as other countries. And we think and we hope that it is because of the strict prevention measures we have. which means schools are closed now for 5 weeks. They will be closed at least for another 2 weeks and only gradually being opened up. Only small groups of people are allowed to meet on the streets. We have very strict distance rules, and still most shops are closed now again for about 4 to 5 weeks. And a very, very smooth opening will start next Monday. There's a little bit of literature about COVID-19 and associated death in Germany. And the first publication came from the University of Hamburg, where they performed autopsies. And the people who died there were in line with what I just told you. They were about 70 years old. Most of these patients were male, 75%. And most of the people died in hospital. And most interestingly, and this is now the intro to what we have to discuss about, most interestingly, these patients, comorbid diseased patients, mainly coronary artery disease, which is about 50%, but also severe chronic lung diseases as asthma or COPD were found in these people. And something which we now find more and more in the literature and also in our patients is that many of these patients have thromboembolism. About 60% of the patients in this small German cohort developed deep vein thrombosis, and 4 of these patients had a pulmonary embolism, which then was the cause of death. So also, I think important for us as pulmonologists to know that pulmonary embolism is extremely frequently to be found. If we compare these data to data we have from China, we see this is very similar. And one of the leading chronic diseases in our field is COPD. And we do know from a recent meta-analysis of more than 1,600 patients that COPD is associated with an extreme high risk for a severe course of COVID-19. And in general, we do know that comorbidities are extremely associated with poor clinical outcomes. One very important question is, what about the role of smoking history? And there comes a recent systematic review of the evidence, combining 5 studies, which all have been performed in China. Some were retrospective, some were prospective. And the sample sizes were something between 40 and 2,000 patients. And there we very clearly see that there's an association between smoking and the risk of more severe symptoms, and especially being admitted to intensive care ventilation, the need of mechanical ventilation, or especially death. And also, we have some data on the association between COVID-19 and more severe courses here from Germany. And one of my colleagues from the University of Aachen just very recently published his first experience of patients with COVID-19 on the ICU. And they compared patients who developed ARDS and those who only were in need of oxygen supply. And especially here we can see that most of these patients who developed ARDS were affected by either chronic obstructive lung disease or asthma or other pulmonary diseases, and which if you count these figures together, about 60% of the patients who developed ARDS had chronic respiratory diseases, compared to only 40% of those not, which means that we as pulmonologists are extremely important also in the treatment for our patients. And one of the questions is how to prevent complications is, for instance, if vaccinations might be helpful. And what we have seen, this is mainly again data coming from China, is that bacterial infections are extremely important causes of death or of morbidity in the COVID-19 affected patients. So if you compare the survived to the dead patients, in one of the Chinese cohorts, about 80% of them had a bacterial infection. And the gold report of this year underlined that vaccination for COPD is extremely important, pneumococcal, but also against influenza, at least as long as there is the influenza season, or better to say, which will start in the southern hemisphere very soon. What about treatment with regards to COPD? Well, there is a couple of discussions about anti-inflammatory drugs, for instance, like steroids, and there was a warning in France that this should be avoided. However, there's a couple of data in the literature now. One of the best comes again from China, which was recently been published in the JAMA Internal Medicine. What they have found out here is that those patients who received prednisolone had a better survival rate than those who did not. However, there is contradictory data coming out, and to the general aspects of immunosuppression, we have to discuss a little bit later on. So the Gold Committee recognizes that people with COPD are amongst those worst affected by COVID-19. However, there is no scientific evidence, which was also summarized by Gold, that the inhaled steroids, which are being used by many COPD patients, that should not be avoided currently. And Gold recommends that COPD patients should maintain a regular therapy, which for a first interim summary means that for COPD patients and for smokers in general, there's a higher risk of a more severe COVID-19 infection, and vaccinations are recommended, and also that the treatment should continue in our COPD patients as they were outside of the COVID-19 pandemic. What about asthma? There the data is very, very weak. There's a German recommendation because some virologists here in Germany discussed about that inhalative steroids should be avoided in asthmatic patients during the COVID-19 situation. However, we as the German Society for Pulmonology stated that inhalative steroids for sure should be continued, otherwise a higher risk of acute exacerbations should be faced. And also there is a discussion coming from some, again, Chinese data that a lower eosinophilic count is found in COVID-19 affected patients, and some non-pulmonologists derived from that anti-eosinophilic treatments, the biological treatments, should be stopped during this. However, several guidelines and societies, including German societies, recommended to continue biological therapies. And also the American College of Allergy, Asthma and Immunology didn't see any signal for a higher mortality risk in a well-controlled mild to moderate asthma, and they all recommend to continue anti-asthmatic therapy, including biological therapies. So then the last point I would like to highlight very shortly is what about interstitial lung disease and immune suppressive therapy. And this is a little bit disappointing because we do not have any data yet. We are in an international discussion group of ILD experts. We do see that, yes, for sure, ILD and IPF patients get affected. However, it seems only mildly affected. However, there is no data out there. And also, there was in the beginning some warning about immune suppressive therapy, but you may have heard that there is a cytokine storm associated with COVID-19 infections. And what we do see is that whatever kind of patients, but especially our ILD patients who receive different forms of immunosuppressive therapy, are not currently associated with a higher risk of more severe COVID-19. So that we hope that the immunosuppressive therapy could be continued, and that is what currently is internationally recommended by many experts. However, research has to go on, and we need more data to be published. Just give me 2 more minutes to discuss about the therapeutic approach we follow here in Heidelberg. So from all the treatments, you know, they are all off-label, and data are very, very weak. So what we do is here we use chloroquine or hydroxychloroquine, which is known that it inhibits the viral entry and endocytosis, and we hope that it is for the more milder affected patients helpful. And in those patients where we do see a cytokine storm, we then give these patients tocilizumab. However, as everybody in the world, we have to acknowledge that it is, on one hand, very weak data, that it is off-label, and that we need more data to come in future. In Germany now, the use of convalescent plasma or hyperimmune immunoglobulins is also discussed, but it's in the beginning. So with this, I would like to stop here, thanking you for your kind attention. And we do know a little bit more about chronic lung diseases. However, there's a lot of open questions, especially with regards to those severely affected by fibrotic interstitial lung diseases. And with this, thank you very much and looking forward to the further discussion.
Yes, sir. Sir, thank you so much for your wonderful overview of how to deal with the chronic lung disease in this COVID-19 pandemic. So we will have a good discussion. I have a couple of questions, sir. So in the pulmonologist perspective, this COVID-19 pandemic, after the session of a radiologist who is waiting with our India's reports on CT and ultrasound and imaging perspectives in COVID-19, sir. So after 10-15 minutes, can you please stay with us so that we can have a nice discussion? Then we can. So, okay, sir.
Dr.
Yes,
Yuvarajan, you can ask him
madam.
a couple of questions if you want, because I'll start at 50. You can ask one or two questions. Yeah.
Okay, madam. Okay, madam. Okay. Sir, just let me ask you one thing, sir. Initially, I've discussed with you regarding the incidence of comorbidities in COVID-19. There is a published data from China, published data from Italy was there. So all the data they are telling is that the comorbidities like diabetes mellitus, hypertension, and cardiovascular disease usually is a predominant when compared to CRD, chronic respiratory diseases. Sir. There was a nice editorial which was published in Lancet on April 3rd. So they also noted out that these comorbidities of chronic respiratory disease are far less noted in an article from Italy, from the group of Italy, compromises around 355 patients. So they told that 20% of their comorbidities usually diabetes mellitus. They not even documented a single case of chronic respiratory disease in that study. So it's maybe a largely under-recognized one. What is your view on that, sir? Both the things they are telling that diabetes mellitus and hypertension is one of the most common comorbidity. When you see globally, CRD is very common, like COPD and all. So what is your view on this, sir? Like they published the paper. So what is your view on this, sir?
Well, there's a lot of discussion about different aspects. So first of all, let's comment about hypertension. So hypertension is extremely frequently in those patients who are admitted to ICU, because that is the typical patient population affected by hypertension. So most of the patients are around 70 years old, about 70 to 80% of them have arterial hypertension. Which brings us back to the question, is the use of ACE inhibitors or SARTAN something which makes people more susceptible to more severe COVID-19 infections, or vice versa, because there's no it might even be more prohibitive of the severe infections.
Yes,
I think the data on this are very unclear. So if we try to compare that to data we do have on ACE inhibitors in IPF, we have seen that whatever it's doing, it might be a little bit it might be associated with a little bit better survival. And so I don't follow the idea that that ACE inhibitors might people more prone to more severe infections. So I think we need a more solid database on that. And from the currently ongoing basic research, we don't have new insights that the use of ACE inhibitors is associated with a worse or more detrimental outcome. So I would continue that. But in general, we do know that many comorbid conditions make patients with COVID-19 more susceptible to more severe course of the disease. And I think this is something we also see in pulmonary diseases very commonly. there's a new hypothesis showing that there might be an association between COVID-19 kind of a very mild myositis, or especially cardiac myositis. So perhaps that is something which has to do with it. However, what we need to learn more is what about the association between, because the Milano area is something where we do see a lot of air pollution, whether there's not a distinct role between air pollution and COVID-19, something again we as pulmonologists have to be aware of.
Sir, my second query to you is this, sir, those patients, many of the patients of particularly with CTD related ILDs, connective tissue disorder related ILDs. So these patients are on steroids and immunosuppressives. What is your view? So shall they continue the steroids and immunosuppressives the same dose? Because prolonged immunosuppression has worst outcomes in COVID-19 based on various reports. What's your, as a expert in interstitial lung disease, what's your view on this?
So there's different aspects. So let's start with another, because this is the only recommendation I'm aware of. Let's start with LAM and the use of sirolimus, which is also an immunosuppressant. Yeah. And there's the American Association for the patients affected by LAM, and they recommend to continue this drug, which I also recommend. Yes. The second aspect is the role of IPF and the continuation of antifibrotic therapy. There's a couple of experts discussing
yes, sir, yes,
you should interrupt that therapy. However, I'm not in line with this, because if we have a severe viral infection, this could mean that it might lead to an acute exacerbation. An acute exacerbation hopefully might at least a little bit be preventable by antifibrotic therapy. So I would continue as is. And what we see, at least in the gut feeling from many international experts, is that IPF patients might be affected, however, not severely affected by COVID-19. And then lastly, what about all these patients who receive immunosuppressive, immunomodulatory therapy, either diseases or HP or whatever? So what we do is we currently continue this. We give our patients very strict hygiene measures, so hand washing, disinfection, mouth masks, and so on and so on. And we continue the therapy because I'm fearing that any further progression or any further deterioration of the disease might affect the patients even more, and then we need higher doses of, for instance, steroids, and then the risk is very high. So we try to lower the dose of steroids as good as we can to 5 milligrams or 7.5, but we continue the rest. However, if we do have an infection, then we interrupt treatments like azathioprine or so on until they do recover.
Yes, sir. Thank you so much, sir. So that what I could understand is that we have to continue that, and we have to minimize the dose of steroids. That is the thing I could understand. Yeah, sir. And the last one important query is that, sir, those patients who got recovered from COVID-19, so we are getting reports that these patients have pulmonary fibrosis as a sequelae of ERDS. And this pulmonary fibrosis is this is not usually fibrosis of ERDS. Even BTS also they have noted in their statement that all the ILD experts has to decide on this because they are telling that this fibrosis, whether it will progress or it will be static, whether we will face some additional group of fibrotic ILDs in future, because it involves large group of population. And I could see some of the trials of fibrodone, this perfenadone, that is registered in FDA for this purpose. So what is your view on this, sir? That is a post-sequelae COVID-19 fibrosis. Whether we need to think a lot on it, and what is your view on that?
Well, we have seen at least a handful of patients with post-ARDS fibrosis over the last years, because these patients are being referred to me with the question whether they have post-ARDS or any other reason for developing pulmonary fibrosis. And what we do see in those where we then finally diagnose post-ARDS fibrosis, that these patients, yes, they have lost of their lung volume, however, they remain stable over years. So currently, I think and hope that we will see the same in those affected by RDS and post-RDS after COVID-19. And currently, I do not see any indication for an antithrombotic therapy because I assume that these patients would remain stable. However, there's a group of experts currently thinking about a clinical trial of follow-up of especially patients also with CT so that we can learn about the behavior of post-RDS. But currently, I would not recommend antithrombotic therapy for those.
Okay, so last most important query, sir. I'm sorry, host. There is some. Can you just mute all the other mics? Can you just please mute all the other mics? Sir, last but not least, the ARDS, what we are seeing in COVID-19 pneumonia, we could see the reports from critical care societies that it's totally atypical. Host, can you mute all the mics, please? Can you mute all the mics, please? So, sir, can you hear? Yeah. Sir, can you hear me? Yeah. Sir, this ARDS is usually atypical ARDS. What we usually in ARDS, the ARDS in COVID-19 is totally atypical. This is what from the reports from various critical societies are there. And the complaints also a lot of variation in the reports that was published. So, what is your perspective on this, sir? There are certain people who are advising higher PEEP to maintain the oxygenation as per the ARDS net trial. There are certain people who are telling that compliance is far good enough in most of the patients of COVID-19. So we don't have to use higher PEEP. We have to maintain a low or modest PEEP only. What is your view on this? In Germany, what you are following? Yes, sir. Please.
This is a very good and very complex question. And currently, there's a lot of debate on this aspect here in Germany. So there's a lot of people who still favor very early intubation and sedation and prone position ventilation, something I recommend and support. However, there's others saying that non-invasive ventilation should be initiated very soon and followed as long as possible, utilizing very high PEEP. However, I would fear a structural due to the use of high PEEP. So my personal opinion is that high PEEP might perhaps do more therapeutic sparring due to AIIMS.
Okay. So, sir, how often you screen the patients for PE and DVT in patients with COVID-19 pneumonia? Because we are getting a clue that the hypoxemia is not only because of ARDS. It's something beyond ARDS we are dealing with. So what is your view, sir, in your hospital and your
I'll help you with all the background noise I understood you. So about pleural effusion and deep brain thrombosis?
Yeah, this is in pulmonary embolism and DVT. Yeah.
So I think from the data we learned also from that autopsy study here in Germany, I think we have to be very aware of that we have to be very much aware of thromboembolic complications. So we give all our patients who are diagnosed and are hospitalized, and they can walk around. We use prophylactic anticoagulation because we are freeing this. And once we see that they are deteriorating, then we also rule out pulmonary embolism. About pulmonary pleural effusions, we do not see many patients. I'm aware of other centers where they see lots of pleural effusions. However, we don't see this very commonly.
Okay, sir. So thank you so much, sir. Thanks for joining with us for this wonderful day. So shall I just move on to the next speech, sir? If you want to tell anything, you can just proceed, sir, please, sir.
Okay, just a short question because I have some other duties. Do you still need me? Then I can call in again, or
sir?
Do you still need me? Then I would call again, or
Yes, sir. Yes, sir. Yes, sir. Maybe after 10-15 minutes, please join us, sir, for some queries from audience. Okay. Yeah, I will just move on to next talk, sir. Please, sir. Okay. Just spare for 10. Okay. Thank you, sir. Thank you, sir. Thank you so much. I think.
Yeah.
I think. Shall we move on to the next talk by Madam? I think Madam doesn't need any introduction. She is a professor of radiology in All India Institute of Medical Sciences, and present she is also the president of Society of Chest Imaging and Interventions. She initiated and head the Radiology Fellowships program in AIIMS, co-founder of radiology courses in AIIMS, and she had a number of national and international publications. Over to you, Madam. We are very eager to hear what are the radiologist's perspective the diagnosis of COVID-19 pneumonia.
Yuvarajan, can you see my slides, and is my audio all right?
Yes, ma'am. Audio is okay. I think slide I could not see, ma'am. Yes, now I could see, ma'am. Yes, ma'am.
All right.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yeah.
So some of these I'm going to discuss what the imaging workflow is going. Our plan is, or what we are following in COVID-19 pneumonia in India, and also share a few cases with you, which have been shared by some are our own cases, and some have been shared by students and friends across the country.
Yes,
whatever I show today in terms of what our recommendations are, it is understandable, that it is an evolving disease. People have different experiences. Facilities are going to be different from one center to another center. So the imaging strategies you follow also will be different based on your resources. But this is a broad guideline which we brought out to say that the basic tool of imaging in India for COVID-19 has to be the chest radiograph. The chest radiograph has to be coupled with the bedside ultrasound or the point of care ultrasound, and supplemented with CT in moderate to severe disease. And I will go on to share with you the specifics of how we will go about this. Now, there are three groups of patients. One, patients will be patients who are COVID-19 positive confirmed. One group will be COVID suspect. And the third group that I'm going to discuss with is subsequently when I come to CT, that you don't suspect COVID at all, and it comes as a surprise on radiology. Then what do you do? So let me start with the first group, that is when the patient comes to you as a COVID suspect, that means the patient has severe acute respiratory infection as per WHO definition. What do you do? So if the patient has no lower respiratory tract symptoms or shortness of breath, imaging as such cannot help you exclude COVID. It cannot diagnose COVID, it cannot exclude COVID, so there is no role of performing any imaging. But for all SARI, the current recommendation is that either you do a chest radiograph, or if your ER facility is good with following the blue protocol, you can do the POCUS at that point for dividing patients into pneumonia versus non-pneumonia, which is the usual triad symptom which is followed according to community acquired pneumonia guidelines. This is if any suspect comes to you when to image. In patients who have already tested positive, how often to image and whether to image at all or not. If they have already tested positive, and if it is a mild case, especially those who are in home quarantine, on home isolation, what India is talking now of 3 levels of medical institutions also, you do not need any imaging. If patient has no shortness of breath, is stable, you do not need any imaging. However, if the patient has any underlying disease, such as elderly age, cardiovascular disease, COPD, CKD, or has any low respiratory tract symptoms, you need to at least do a chest radiograph. The strategy will change once we label the patient as moderate or severe disease. We will have to do chest radiographs regularly. If we see any deterioration on this, ideally, you can do a point of care ultrasound so that at least simple things like pleural effusion and also, DVT pulmonary embolism, which you were bringing out, you can do your DVT scan, you can see the interventricular septum, you can see the right heart, whether there is right heart strain or not, and take a call that is it due to either of the two P's, pleural effusion or pulmonary embolism. If the worsening on chest X-ray does not get explained by this, or you do not have facility or expertise for doing bedside ultrasound, then we go in for CT. So CT is reserved for moderate to severe cases with unexplained findings or clinical deterioration. Now let us see some cases. An individual modality on how we will go about interpreting this. Now, chest radiograph, first group we have already said that if patient is suspect, for our own screening OPD, as the number of people reporting to the ER is very large with respiratory symptoms, we have laid out criteria on when people need to go in for a chest radiograph. Basically, any SARI with shortness of breath or any level of hypoxia needs to go in for an immediate chest radiograph. And we have isolated this machine and kept it separate from the main ER where the patient will go for chest radiograph. In COVID-19 patients, we already dealt with this, that in moderate to severe symptoms, there is no doubt chest radiograph should be done. But in those with mild cases, you can do if they have underlying diseases. There is also a Ministry of Health and Family Welfare guideline which says that once before discharge, do one chest X-ray, although the WHO says it a little differently. So it's entirely up to the institution depending on how many cases you are handling and what facilities you have. But if you can, do one radiograph before you send the patient off. Now we come to, this is from literature of the spectrum of findings which have been reported in COVID-19. They talk about consolidations, and we will see a lot of these cases through the presentation to understand what kind of consolidation. But what is typically described is consolidation, which is either perihilar in location or peripheral in location. Yeah, it's either centered around the hilum or at the extreme periphery, with pleural effusion being seen in much fewer number of cases compared to, say, a bacterial pneumonia. But that is true of every viral pneumonia. We see that it's not common for us to see pleural effusion, whether it is H1N1 or in other viral strains also. After a chest radiograph is performed in any patient with SARI or a COVID-19 suspect, the radiologist should clearly, after reporting, be able to put this into one of the four categories. One is that you say the chest radiograph is normal. It doesn't mean there's no COVID-19, but it just means there's no pneumonia. The chest radiograph is normal. Or you say clearly that it is abnormal, but it's not COVID. If you see florid lobar pneumonia, you see classical changes of pulmonary tuberculosis, you can say it is not COVID. And then there are these two categories in between, which has that classical, that the first possibility is COVID, and then indeterminate, which means that can't say. It can be. It can still be a COVID. So these two categories kind of somewhat overlap. But if you see a lower lobe predominant, peripheral, consolidation, and ground glass, you can label it as a classical COVID. Let us see examples. Now, this is one of our COVID-19 patients. As you can see, that patient has severe disease because patient is already intubated in the ER. And this is the classical picture of the peripheral consolidations. What we use the word, of like a reverse bat wing, we use in context of eosinophilic pneumonias and all. But in COVID also, what you see is a lot of peripheral consolidation. It says lower lobe dominant, but for instance, in this case, it's not really lower lobe dominant, although it does spare the apices of the lung. So this picture represents the classical picture of a COVID-19 patient. This is another of our COVID-19 proven patients. And this patient has a focal area of consolidation. Now, what is classical about this focal area besides its lower lobe and peripheral location is that it looks very round. When I come to CT, I will show you that this round configuration is another point which has been emphasized as being very suggestive of COVID-19. Yeah, so this would go in indeterminate category if you were doing it in a suspect, but we're doing this in a known patient of COVID-19. So we know that this is a COVID-19 disease. This, for instance, will get labeled as non-COVID. This is a lobar consolidation, which has areas of breakdown inside it. So depending on what kind of clinical presentation is there, what the TLCs, it could either be a bacterial pneumonia or could even be active tuberculosis. So those will be our two possibilities. So we can clearly say that yes, there is pneumonia, but it is of a non-COVID pattern. Yeah. So at the end, you should be able to, as I said, categorize into one of the 4 patterns: COVID, non-COVID, or normal. So amongst COVID, you can say probable or less likely. Once you do it in a non-COVID patient, a patient who already status is known, it is a good idea to indicate the severity of the disease to the clinician in your report. So that is why we have devised this structured reporting format and this score, which we advocate that please use it if you are doing it in a known COVID-19 patient. And this 6 zones, 4 being the worst score, means 24 is the worst score. So when you reflect, so if you say 2 by 24 or 16 by 24, the 2 things mean very different to the clinician, and they can correlate the clinical severity with the radiological severity. It's very important because when you are going to follow up, instead of saying less, more, it's a good idea to say how much less or how much more on serial radiographs. Now we come to chest CT, although the bulk of published literature has been on chest CT because it was initially, when it was done, the disease came to Wuhan and people were not sure what it is. A lot of CTs got done, but at the end of the day, most guidelines now across Europe, North America says that CT is not a tool for diagnosis. CT is not a tool which should be used for screening or diagnosis of COVID-19 because it does not have that level of specificity. Also, unless you dedicate a scanner only to COVID-19 patients, it's, you'll have to sanitize and sterilize the area each time, especially even if you do it for a suspect. If you do 2 suspects who one later comes out positive, one later comes out negative, even between the 2 suspects, you will have to sterilize because you can't risk transmission from one patient to another. That is why the use of CT is limited to patients with moderate, especially severe disease, where you are looking to prognosticate the disease. You are trying to see how much the ARDS is, in which also we advocate that before you take the patient down to CT, please do a point of care ultrasound for 2 reasons. You can exclude if, for instance, it's a pleural effusion. Suppose you do find right ventricular stain and features of pulmonary embolism, then you need to go for a CTPA, a pulmonary angiography. But if you are just doing it for ARDS, you need to go for an NCCT. And that decision cannot be taken without doing the bedside ultrasound. That will help you plan your CT also. And of course, even the few patients that we have in ICU in our hospital, they are not asking for CTs from us frequently because of the problem of shifting a patient even in a COVID created corridor, but still it will entail the use of so many PPEs in shifting the patient through that COVID corridor. So maximum information should be given through the combination of chest X-ray and ultrasound. And if required, of course, you go down for CT. But still, I'm going to discuss a lot of CT patterns. And why are we going to discuss CT patterns? Because a lot of CTs are getting done today also in the community for people who are not giving history of travel, or I don't know whether it's community transmission, but in majority of cases, the contact is traced and patient is either not aware or concealing history. So CT becomes the first modality which kind of suggests that this can be COVID. That is why it is important that we use the Chinese and South Korean experience and learn to recognize what COVID looks like. So that if we incidentally pick it up, then we should report it as COVID. Again, the language used by RSNA is little different in chest X-ray and CT because that one was from the British guidelines and this is from the American guidelines. But broadly, it is same, that you either say normal, or you say not COVID, or you say, either typical or indeterminate. Now we'll see examples of all these 4 categories. Excuse me for the quality of some of the images because I shared with you as they have been, sent to be my colleagues, friends from all over the country to share what they faced. So for instance, this is a patient from Srinagar in J&K who subsequently passed away soon after his CT, who is showing what I showed you in the chest radiograph, what is being described as the typical pattern of COVID-19, which is peripheral subpleural consolidation, which has a distinct lower lobe dominance. So this is a picture that you need to remember. And if you see it in the current season, you have to raise an alarm and send patient for COVID testing. And what happens if you detect this incidentally? You know, currently there is a school of thought, and we have also started following in our institute, that perhaps at least lower two-thirds of chest should be included in every CT which is done for other reasons also. Even if you're doing an abdomen for intestinal obstruction or trauma, look at the chest also. And if you see this pattern, you can raise an alarm for COVID-19. This is the classical pattern of COVID-19. Just to show you the area of consolidation better. So this is known as the first category, which is typical appearance, peripheral bilateral consolidation. As I show you the cases, you will see that a lot of them show the crazy paving pattern. Crazy paving pattern superimposed on this consolidation. Another classical pattern being described is this rounded morphology, multifocal ground glass or consolidation, and there is a rounded morphology. The reverse halo sign, typically described in organizing pneumonia, mucormycosis, has also been described a lot in COVID-19, and we will see all of these. This is also a shared case from somewhere, which shows the classical round, which we are talking. So you see, these are not peripheral. Some of these are central, peribronchial, some are peripheral, but they have this very rounded configuration. And some of these also show you central clearing, suggestive of the Atoll sign, which in other times, you know, you would have thought of organizing pneumonia, even a CTD. But in current times, if you see a CT like this, it means that you again raise an alarm for COVID-19. Now I'll share a couple of cases with you to show how it goes. So this is a 25-year-old man who came with shortness of breath. All the CTs that I have done shown so far, and which I show now, were done with patients who did not give any history of contact or any history of travel. That's how the CTs got done. But they did have SARI, so they had breathlessness and they were taken up for CTs. If you see the CT, you see multifocal consolidation, but it's not exactly, you know, peripheral in distribution. It has started right from the upper lobes, and it's not exactly rounded, although I would say that some of them are starting to show this central clearing. And as we go down, the rounded configuration also becomes obvious. See, this is the peribronchovascular distribution, which is being described more in young people and children. And as you see, these now tend to take on a rounded configuration, but look at the rest of the lung. It shows you interstitial pneumonia like you see in other viral pneumonias. So now as we go down, the peripheral consolidations also come, although they are not as classical in distribution as we saw in the first case. So what would you label if you saw a case like this? This is the topogram of the same patient. You can use the category name indeterminate, which means that it is still suggestive of COVID, but it can be other organisms also, such as other viruses. So these are also multifocal, diffuse, perihilar, but may not show you the classical peripheral or rounded distribution. So this is the second category. Show you another patient of the second category. He's an 18-year-old boy, but his symptoms were about 1 month, while the shortness of breath was only 5 to 6 days. And this is a common history to all of them. You'll run through these images with me, looking very similar to the previous case. Ground glass, a lot of ground glass, which keeps getting more as we go down. Some of these are like ill-defined GGO-centrilobular nodules. And then this classical type of peripheral consolidation starts to come like we saw in case 1. And as we went down, this peripheral consolidation gets denser and denser and assumes a rounded configuration. As you can imagine, after we did the CT, we completely freaked out and we rang up the physician and said, why did you send down for CT without doing the COVID-19 test? But the clinician was insistent that it's a 1 month story, madam. I've seen lots of chest radiographs and it's not fitting in. Regardless, we closed the CT down, we sanitized it for 3 hours, and we said, you test. And it was tested. By the time we got the report a few hours later, it came out negative. So it looked very similar to the case which I just showed you before this in terms of peripheral distribution. but the history just wasn't fitting in. But regardless, we have to test. Then we reviewed all the investigations, and this is what had freaked us out even more. I said, patient has leukopenia, patient has that radiology, and you didn't test for COVID-19. And what did we find? We found very high eosinophils. After that, the microfilaria antigen was done, which was positive. Patient belonged to Eastern UP and has been started on Hydroxychloroquine, and it's been about 10 days since and is already starting to feel better. So as I told you in the beginning, eosinophilic pneumonia, or like in this case, tropical amongst the eosinophilic lung disease, tropical pulmonary eosinophilia can be a very close mimic. But regardless, if you see the pattern on CT, you need to get it tested. And world over, every radiologist is saying that I am overdiagnosing. That will happen. You know, you will overdiagnose. But regardless, if you see any of the top 2 patterns which are seen, you have to raise an alarm for COVID, close your scanner, sanitize it, and only then take on the next patient. The other 2 are simple, that you say it's not COVID or you say it is normal. Again, similar to chest radiograph, we have devised a score, and you know, it is advisable to give a CT severity score once you have done the CT scan. This is the last patient, which was shared to me by a friend from Kolkata, of a patient of CKD who was on maintenance hemodialysis. He had no fever, but the breathlessness of the patient was not getting explained due to pulmonary edema. And besides, the nephrologist said that I am giving hemodialysis thrice a week. Why should the chest radiograph be looking like this? And why should the patient be so breathless? That is why the CT was done. And the CT, pardon me for the images, but as I said, that they are shared images and they are a treasure because I don't have another case like this, shows you what Dr. Yuvarajan said, and some of you who may have attended yesterday, what we call the atypical ARDS. Now, what is the atypical ARDS? Which means there are 2 components to it. One is the classical ARDS, which is in the bases, but one is this rounded consolidation, rounded areas of consolidation, which are in addition to this ARDS. The combination of these 2 raise the possibility of this being a pulmonary cause rather than an extrapulmonary cause of ARDS. And amongst the pulmonary causes in current scenario, especially with presence of atoll sign, rounded configuration, COVID SARS becomes the first possibility, and the patient died within a few hours after the CT, and subsequent testing communicated to the center 2 days later confirmed the COVID-19 status. So a lot of incidental patients are reporting to non-COVID hospitals, for which the radiologist has a very important role to play. Ultrasound, I'm not going to go into detail. Suffice to say that blue protocol for screening, and please, those who are interested should read this very nice article on the COVID focus protocol which has been proposed. I will just summarize what our strategy and experience is. As I said, divide them into 3: proven COVID, COVID suspect based on imaging. So this is this category I already told you in the algorithm, and this is the category I try to highlight through cases, that when does a patient become a COVID suspect based only on the imaging patterns. And this is a recent document from the Fleshner Society, which broadly agrees with the very similar to the guidelines we are proposing. And these are the times we live in. Sometimes truth is stranger than fiction. Never thought you would see this in a lifetime. Thank you very much.
Thank you. Thank you so much, ma'am, for a very informative session on imaging, particularly in this COVID-19 pandemic season. I think a couple of questions to you, ma'am. Like there are some reports from China and also from European countries, like CT can be used as a screening modality. What is your view on that, ma'am? Like there are contradictory statements there. I think American College of Radiology, they told that you should not use it, and it will never replace your microbiome.
Yes. So see, the Chinese experience was early. You know, at that time, they did not know what they were dealing with. We are a little wiser because having seen all their experience and the European experience, because we are a couple of weeks behind Europe also, and South Korean experience, it is not a screening modality. You cannot confirm or exclude COVID. Having said that, there is that 48-hour gap at the moment between suspecting and confirming. But in that gap, it's best to do a chest radiograph, isolate your patient, and take a swab and wait. Unless the patient has severe disease, when you have no option, but then you have to, every patient you take into the CT suite, you have to take in with whatever will now become universal precautions for COVID. If you have the resources, yes. If you have everybody's in PPE, you have a separate scanner or a separate timing when you can sanitize it, you are welcome to do it, but it's not a modality for screening.
So what about the incidence of PE, pulmonary embolism among the COVID-19 pneumonia? Did you experience any patients from you got any case of CT
no,
pulmonary angio with
I'll tell you the, our experience is we have about 150 to 170 patients who are in our NCI Jhajjar. And then we have about 6-7 patients who are more sick and require ventilatory support who are in our main trauma center. Amongst our patients in Jhajjar, we have had only 2 deaths so far. And none of the patients over the last 2 weeks have gone into ARDS or have required any imaging beyond chest radiograph. And the 2 deaths we had, one was because of DKA. By the time the patient brought in, patient had not eaten for a while and had gone into diabetic ketoacidosis. So combined with the infection, patient died because of that. The second patient had like a sudden cardiac death. And in media also, you may have followed that, some people are reporting sudden death. A patient who is apparently normal and then is gone within minutes. Now, I don't know whether that is a cause due to myocarditis or was it pulmonary embolism. So those, but as such patients who have come to us and been with us, we have not encountered pulmonary embolism, and none of the radiologists have shared that with me either.
Any of your experience on sequelae lung, like after ARDS or something like that, after pneumonia? Like there are a lot of reports that BTS also raised the alarm to pulmonologists with perspective looking into the ILDs. So they are telling that this fibrosis, we have to look into it, whether it will progress or it will be static like ARDS. Any view on this, ma'am?
So no experience as yet on COVID-19 in specific, but I will tell you in context of ARDS, in context of AIP, which is also, presumed to be precipitated by viral infections, very definitely long-term sequelae are definitely a problem. And based on the radiograph, based on CT, based on, combination of ultrasound, you will be able to, predict that how many patients are likely to get fibrosis. So in ARDS, which is non-COVID, there is a lot of literature on what is now, I did this yesterday with some of my students, now being called alveolar recruitment, which means how many of alveoli can still be recruited and will, re-aerate once the ARDS passes, and how many will go into fibrosis. But because, of the high contagious nature of this disease and the limited ability to do repeated, like, in ARDS, when we predict, you do the CT at 2 PEEP settings. When you do the CT at 2 PEEP settings, then you can make out that how much is the difference in the inflation, and you can predict the,
Yes, ma'am. Ma'am, shortly stay with us, ma'am. I'll just call Kreuter sir for some more questions and then we'll conclude. Yes.
Okay.
Thank you, ma'am, for the wonderful session. Sir, Professor Kreuter, sir. Sir, are you there?
Yes.
Sir?
Sure.
Sir? Yeah. Yes, sir. Sir, sorry for just making you to wait. Sir, there are a couple of questions from audience from India. So, sir, there is one question from Dr. Girija Pondicherry, sir. What are the ventilator strategies to be adopted for better response? Like the same question I asked you previously. Shall we follow the universal protocol, what we do in ARDS settings, or we have to keep high or low PEEP like that? What is your view, sir, in this?
This is, again, very similar to the question you have posed. So I think we are all learning. The most we can learn from our colleagues in China and also in the US. However, the protocols there are very different. My personal protocol is prone position. However, what we do in our center is in patients where we do see that oxygenation and ventilation is a problem, we use ECMO very early. So perhaps this is a third important point.
Okay, ECMO you are opting, sir, for refractory hypoxemia in Germany.
Yes.
ECMO you are opting, sir, in this COVID-19. Okay. So what is the success rate, sir, for ECMO for refractory hypoxemia? Your views on that, sir. What is the success rate? Yeah, how like because a lot of patients will be there. How do you recruit the patients are on ECMO, and what are the problems you faced in refractory hypoxemia? Those patients put on ECMO.
So we use ECMO in several patients. We have some experience with the use of ECMO in ILD patients in general. For instance, in ILD patients with connective tissue disease, or so for instance in antisynthetase syndrome or in lupus and so on. And we have there very good experience that this is a very good bridge until the immune suppressive therapy, rituximab, cyclophosphamide, or whatever is helping, and the ECMO is a extremely important and helpful tool. For COVID-19 in Germany, you have a very strong ECMO society here, and ECMO is used very early also to prevent morphologic scarring of the lung due to ARDS. And so I value ECMO in this situation very much also in the COVID-19 situation.
Sir, as Madam has just shown the nice radiological pictures like CT findings like, reverse halo sign, the pattern of organizing pneumonia. So, so what do you think, sir? This patient will have a progressive forms of interstitial involvement, or that will be like a static, like what you see regularly in viral pneumonia? What do you think, sir? Like, what is your view? Like, after a few months, if the patient come back to you, like those who got recovered from severe pneumonia, so is there any possibility that we will deal with any fibrotic forms of ILD? What do you think,
well,
sir?
This is again something we discussed with one of your questions, and so we don't know what the outcomes are.
Okay.
What we do see is that the appearance of the IRDS we see in CT is a little bit different from what we have seen in other IRDS forms before.
Yes, sir. Yes, sir.
We see a little bit of continuation of ground glass opacifications. We don't really know why this is. Perhaps it's some minor bleeding events, which then also transfer into fibrotic scarring, perhaps due to microembolic complications. But this is currently something which is unclear and unknown and has to be looked into a little bit further. But my personal gut feeling is that the behavior will be very similar to other IRDS patients, and that they will remain fibrotic.
Sir, another question from audience is that can we use pirfenidone, antifibrotic agent, in patients to prevent fibrosis? Because there are some 5 to 10% of cases where the Chinese reports they're telling that they have some worsened fibrosis. They came back with worsened hypoxemia. There are a lot of trials also they registered for this fibrosis. There is some question that can we use it? Like, since we don't have any other drugs, we are using drugs with only with based on observation studies and based off simply we don't have a proper randomized control trial. Can we include pirfenidone? You know, it has an anti-inflammatory. It has a lot of roles there. What is your view on using pirfenidone, sir?
I had a very nice discussion about this aspect with some other colleagues, ILD experts, very recently. So there's two different aspects. The first aspect is if you try to compare the current situation with what we have seen in IPF, then we have to assume that it needs something between 8 to 12 weeks until pirfenidone is working. So this is not a therapy where you have an immediate effect, and this is something why I'm reluctant in giving pirfenidone in these patients. However, what we don't know and which might be advantages to our patients is to use inhaled pirfenidone. However, for this, we would need clinical trials. So currently, I would recommend using it. However, I do see that it might be associated with some beneficial effects.
Okay. So what is your view on giving prophylaxis to healthcare workers? In India, we have a statement from ICMR that we can proceed with hydroxychloroquine prophylaxis for those patients, those persons who are having a high risk of contracting infection. In Germany, is there any practice of giving prophylaxis of hydroxychloroquine?
So first of all, I strongly support this hypothesis. I think that hydroxychloroquine is a good drug, which may work. However, until we do have the data supporting this, we should not use, and we don't use it in Germany as a prophylactic therapy. However, there's sometimes a discussion in patients who need immunosuppressive therapy for whatever underlying disease, not switching that to hydroxychloroquine. But first, I would wait for the trials to publish very soon.
So what is your stand on systemic steroids in patients with severe pneumonia? Because initially reports from China, they told the systemic steroids largely helpful, that hastens the progression of ARDS, that hastens the progression of severe pneumonia. But recently there are a lot of lot of reports that from Europe only, they are telling that it increases the morbidity and mortality. So now I had a talk with the Spanish fellows. They are telling we can use high dose of steroids. In Germany, what is the protocol?
So in Germany, we don't use hydrosteroids, and I think the evidence is very diverse. As you just summarized, some says that it is the healing, others say that it is the most detrimental drug we may use. I would use it if I would use it on a case-by-case discussion on the patient, but I'm very reluctant in using it.
So in critically ill patients, how far people are preferring NIV and HFNO, high flow nasal cannula, compared to intubation? Because the NIV HFNO has high risk of aerosol transmission. So whether in Germany, these two protocols, these two interface are being commonly used, or what is your view on this?
So I'm a big fan of high dose oxygen outside of COVID-19 because I see a lot of relief, especially in ILD patients. But I also share the concerns about viral transduction during the use of these in the COVID-19 situation. So there are some experts here in Germany advocating the use of that. However, I also see the very high risks for the medical staff for very high exposure. So again, here I'm reluctant, but in general, we use it very frequently.
Okay, very frequent. Okay. So there are some terminology like happy hypoxemia. There are certain group of patients, they look completely stable. They don't develop any symptoms of hypoxemia, what we see in a chronic lung disease. But particularly the patients with severe COVID-19 pneumonia, they look absolutely normal. Within a matter of 2 days, they collapse. So what is your view on that, sir? Like, because in ARDS, pneumonia progression to ARDS, we'll have a symptoms because we'll have a response of respiratory centers responding to hypoxemia. These patients are quite normal. That made us to think that there is some other pathology is inside other than ARDS. So what is your opinion on this, sir?
Yes, so we also see that. So we see that patients come in with some very mild symptoms, and within 8 hours they are intubated because of severe hypoxemia. And we do think that this is associated with the cytokine storm, and that is one of the reasons why in these patients we use tocilizumab very early, because I think that in this situation these kinds of drugs might be very helpful, and that is something other colleagues from other countries describe as well.
And the madam has pointed out one very good point, is that there are some sudden deaths are there in patients with severe COVID-19 pneumonia without much of explanation. Probably this might be because of viral myocarditis and cardiomyopathy. Sir, in Germany, are you having a protocol to measure biomarkers like troponin, BNP, bedside echo repeatedly to the patients with COVID-19 pneumonia?
This is an excellent question. So we are considering this because we are more and more aware of that. That is also something we discussed already. So I think that cardiovascular diseases as a baseline comorbid condition is associated with a more worsening, and I am sure that COVID-19 is associated with a myocardial problem. So we don't have it in place yet, but we are discussing that.
Okay, sir. There's a couple of questions, madam, sir. Then I'll come back to you. Just 2 minutes, sir. 2 minutes. Madam, just another question to you, madam. Like we see reverse halo sign in patients with COVID-19 pneumonia. So we know that a lot of reverse halo sign, there are different patterns are there based on the margin. We get a thick walled reverse halo sign with reticulations, reverse halo signs with nodules and all, reticulations and all. So what pattern we get usually in COVID-19? Is it similar to mucormycosis? Is it similar to any infectious disease or other TB or something like that? What is your view on this one?
So it's very dissimilar from mucormycosis.
Okay.
Yeah. So although the word reverse halo and atoll is used in both contexts, and mucor we tend to use the classical sign is bird nest.
Yes,
but you know, mucor usually has a large, thick-walled area of consolidation or cavitation. The center, which becomes lucent, actually necroses, and you can see thickened septae. You may even see transfissural extension, and the density of the consolidation and the size of the nodules are much bigger, and the central necrosis is much bigger. So we can't mix it up with mucor or with tuberculosis, but you can mix it up with organizing pneumonia, which is idiopathic. But most of the patients, like the ones which I showed also, which had central halo, also had other features, you know, which suggested that it's not a plain simple cough, but yes, it's very similar to a idiopathic organizing pneumonia or a CTD related organizing pneumonia, but very dissimilar to a mucormycosis.
As you told in your talk that USG is actually largely helpful to avoid, it is easy for, disinfection, all these things. So can you tell us, like, is there any specific findings like you could see in USG thorax, which is, slightly that is more in favor of COVID-19 pneumonia when compared to other viral or bacterial pneumonias?
No, so we are not doing the ultrasound to really diagnose COVID-19. Yeah,
Okay,
the first ultrasound that you do, like the blue protocol, whether you label it as a C prime profile or a B prime profiles, which will, suggest that there is pneumonia. That is, if you do it in the triage, in the ER. When you do it in the ICU, then you are looking for the alveolar interstitial syndromes. So what you get are two things. One is the C profile or C prime, which means that in the anterior lungs, you will get areas of consolidation, disruption of the pleural line, shred sign. But it's non-specific for the organism. It simply tells you that there is pneumonia. But in the flaps and in the posterior areas, when you do and you get an AIS, or an alveolar interstitial syndrome, increase in B lines and a storm of B lines, a curtain-like sign, you know your patient is heading into ARDS. And if your patient is in ARDS and you're managing in ICU, then apart from chest radiograph, you can follow up your patient in addition on the ultrasound based on how many B lines you see and in how many areas you see. You can quantify actually and judge the severity of your ARDS over a period of time.
Ma'am, you know that as most of the critical care physicians and as we also doing a regular bedside ultrasound for our patients with pneumonia, particularly this COVID-19 pneumonia also. What are the precautions we should take, ma'am? We like USG, some people are telling that we should use handheld USGs, preferably it should be a, it should be like that. So what is your view on that, ma'am? Like,
so broadly what we say is, one, that you have to place an ultrasound machine in the isolation ward or in the ICU. It is not to be mixed up with the regular patients. Once you place that, and if all your patients are COVID-19 positive, you have to cover it. You have to cover the probe. You used a plastic cover, or you can use condoms also if plastic cover is not available, but it has to be covered and it has to be discarded between after every patient. Besides that, there are disinfection protocols involving hypochlorite and milder disinfectants, which are little bit vendor specific. What you can actually use on your probe or not, but you will have to take a clearance from your vendor. So one is that you keep it covered all the time, at least even if you're in a COVID-19 ward, all patients are COVID-19. Once you finish, at least once at the end of the day, you have to complete a complete disinfection. So as the Indian Radiology Imaging Association has brought out a complete disinfection protocol and COVID technique, if you wish, it's actually in the public domain, but I can share that PDF also of how to do the ultrasound and how to disinfect the ultrasound. Similarly, how to do the X-ray and how to disinfect the X-ray, and similarly for CT.
Okay. Thank you, ma'am. Thank you, ma'am. Once again, last question to Michael Kreuter, sir. Sir, are you in line?
Yeah.
Sir, my final question to you is that whether you are using antiviral drugs for patients with COVID-19 pneumonia, remdesivir, lopinavir, and all these things which are under trials, whether you are using it in the patients with COVID-19 pneumonia or you are sticking on to hydroxychloroquine along with acetro.
So our protocol, at least in our hospital, sees that we first use hydroxychloroquine, and if we do see a deterioration, a rapid deterioration, and we do see a hyperinflation, then we use tocilizumab, and then we finally discuss the use of inhaled interferon alpha. We had in our protocol the use of Bilateral, so antiviral therapies. However, from the data which have been published in the New England Journal and also from reports from colleagues, I personally doubt strong effects by that drug, so we don't use it quite often, or better to say, we only use it on a very, very rare occasion. For remdesivir, I think the main limitation is that this drug is not easily available. We only treated one of these patients with a similar drug. However, in general, we don't use antiviral drugs, and especially for these, I think we need clinical trials.
So is there anything to for you to tell us, the pulmonologists in India who are dealing with chronic airway disease and interstitial lung disease in the COVID-19 season, sir?
Well, for interstitial lung disease, again, I think there is two different points to consider. The first is there's a hypothetical risk that patients with structural lung diseases, ILD, or especially IPF, might have a higher risk for a severe course of disease and for higher mortality. However, there is some data, or at least discussion around saying from different ILD expert centers all over the world, not seeing many severely affected IPF patients. So whysoever that is the reason, it could be because that the ACE2 is not that frequent as in healthy lungs in an IPF lungs, so that the rice doesn't have a chance to be incorporated. We don't know. So currently there might be a higher risk, but perhaps there is also a lower risk. The second point is immune suppressive therapy. We do know that there's a cytokine storm we just alluded on in COVID-19 patients, and perhaps there is a theoretical chance that immune suppressive therapy lowers the cytokine storm, and thus we do see not so severely affected patients. So what we very strictly recommend is to follow the hygiene measures, and in Germany we have very strict hygiene measures, and I think that is the best thing we could do. We lower the immune suppressive therapy as good as we can, but we continue that, and especially the antifibrotic therapy, I would recommend to continue.
So whether you're using this heparin, enoxaparin as a prophylaxis in your patients with COVID-19 pneumonia?
We use it once they are hospitalized, but not on those who stay at home. But then, yes, we use it.
Okay. Okay, sir. Do you want to ask anything to our madam, sir, radiologist? She is from the Apex Institute of India. So you want to share anything, or you want to ask anything to her, sir?
So first of all, thank you very much. That was a very, very nice slides and very great overview.
Yes.
So we share the same experience you just showed us, and I think it would be very good in the future if we would all align together and publish our data together.
Yes, sir. Thank you, sir. Thank you so much. I think, madam, anything you want to tell, madam, like so that we can conclude now?
So a pleasure meeting Dr. Kreuter, if it can be called a meeting, and a pleasure meeting you also, Yuvarajan.
Yes, madam.
Thank you very much.
Yes, madam. Yes, ma'am. Sir, thank you so much. And thank you, madam, for joining this wonderful webinar, for sharing your wonderful experience. And, we are very lucky to have you in this webinar. And I would like to thank my organizing team and my institute to help me to organizing this event, and also loop in Respira also for all arranging the logistics and all. Sir, thank you once again for accepting our invitation. I would love to have you in future webinars also, sir. Thank you, sir. Thank
It's
you.
my pleasure, and
Yes, sir.
take care and stay healthy.
Yes, sir. Thank you, sir. Thank you, sir. Bye bye, sir.
Thank
Thank
you.
you.
Bye bye.
Bye, sir. Thank you. Thank you, madam. Yes.